This is Beth Van Opstel again, and now we're going to go through how to calculate your maintenance fluids. So this is for fluids that are for a kid who is healthy, and this can apply to both oral or IV, although you'll see this used most when you're referring to IV fluids. So one of the most common methods of calculating is called the Holiday-Seeker method. This has some cool science behind it, which I can give you for reference. You'll hear this called as the 4-2-1 rule, but it's a little bit more complex than that, but it is a really nice shortcut, and this is how most residents here at Rush and in a lot of hospitals calculate maintenance fluids. You can also use body surface area if you want, but the way that this is calculated is you can do it by fluids per day, in which case you're doing everything weight-based. So in peds you have to like doing math, or at least have to tolerate it and be able to do it. And so for the first 10 kilos, it's 100 mLs per kilo per day. For the next 10 kilos, it's 50. And for every kilogram above 20 kilos, it's another 20 mLs per kilo per day. But the easier way to do that, and the more practical, because often, especially with IVs, we're putting in orders for mLs per kilo per hour, is where we get the 4-2-1 rule. So that's the actual way that a lot of residents just quickly, and attendings for that matter, quickly in their head calculate the maintenance. So for an example for that, let's say we have a kid that weighs 8 kilos. So the quick 4-2-1 rule, you just do 8 times 4 equals 32, and that's your rate per hour, so that's mLs per kilo per hour. Alternatively, you could do it that 8 kilos times 100, which would give you mLs per kilo per day, but then you have to divide that whole thing by 24 to give you your rate. And they end up being pretty similar. If you wanted to do a tougher problem, like a kid who's weighs a little bit more, so let's say you have a kid who's 25 kilos. So using the 4-2-1 rule, you would take the first 10 kilos, which would be your 4, right? So you go 4 times 10, so that's the first 10, plus you add 2 times the next 10 kilos, and then 1 times those extra 5 kilos. So 10, 20, 25, that gives you your 25 kilos, and you have to add all those up. So you got 40, 20, and 5, so it gives you a rate of 65 mLs per kilo per hour. So that's your rate for that child. Actually, just be even mLs per hour because your kilos cancel out. So that would be the rate that you could order on the computer or tell to your nurse. Now you remember that we talked about the electrolyte maintenance requirements for a healthy child. So we talked about this in the first video. So your sodium requirements are about 2 to 3 milliequivalents per kilo per day. Your potassium is 1 to 2. So based on that, if you were to actually say take that same 25 kilo child and calculate the total fluids that they needed per day, and then figure out how much sodium it is based on knowing what's actually in, for example, normal saline or 0.9 normal saline, then it would seem like for your maintenance fluid that you should pick something like D5.2 in order to get enough sodium, or maybe D5.45. And it used to be that in the past that our go-to solutions were often 0.45, for example, or 0.2 normal saline. But what we ended up finding based on several studies, including some RCTs and some really pretty quality studies, is that actually D5.9 normal saline might actually be the preferred solution. And we've seen in the culture of at least pediatric hospital medicine that these studies have really changed our kind of go-to first solution for maintenance for a normal healthy child that doesn't have any significant electrolyte imbalances. And the studies have actually shown that there's less hyponatremia associated, and without having an increase of hypernatremia. So what previously made people study this was they were finding that children, even though physiologically it seemed like they should be put on 0.2 or 0.45, were actually having a very high incidence of hyponatremia. And so now our go-to maintenance solution is actually this D5.9 normal saline, or people will just say D5 normal saline as an abbreviation, with some KCl. So maybe 20 of KCl. And it doesn't have to be 20, but remember to put some potassium in there so it doesn't hurt or burn the kids in their IVs if they go through, or it doesn't give some yucky tasting spit out nasty potassium oral solution or a horse pill, because they're really big pills. And so kids and adults, for that matter, don't like potassium supplements in general. So if they're on IV fluids anyway, be nice and add your potassium to it. So lots of different people have speculated why it is that if those sodium requirements that I told you would make it so that it seemed like you need a hypotonic solution, why is it that we're not using those, or why is it that kids have so much hyponatremia? And there's a lot of ADH secretion, which probably is the biggest reason. And there's many, many reasons that the body secretes ADH. Some of these are what I consider physiologic, although some people might argue that they're non-physiologic or also inappropriate, but lots of these apply to kids. So things like nausea, pain, anxiety. So many of our kids who are hospitalized have these symptoms. Stress also. And then there's lots of inappropriate reasons, which you probably learned more about in your first couple of years. For example, like CNS disease. And this might be things like brain tumors or meningitis, for example. Other ones that you may not have heard about, but pulmonary disease actually can do this too. And it's not just the adult tumor, for example, that you may have heard about. It's other things that we see a lot in kids, like pneumonia, or bronchiolitis, or asthma, or bronchoasmonia, as we like to call our special, where we're trying to figure out which it is. But in any case, a lot of our kids have these reasons, and so that contributes to them probably needing a more isotonic solution like LR or normal saline as their go-to solution for them. There's other reasons too, which you don't see as common, but it might be a renal, like a receptor problem, for example, or diabetes insipidus, which might contribute to their sodium balance. But this again is probably in the minority of cases. These are probably the more common things that we see up here. All this to say that if your resident, attending, etc. asks you what your go-to solution would be, then usually it's D5. Remember, don't let them starve. 0.9, or people just say normal saline plus your KCl. And it might be about 20 milliequivalents is usually kind of a go-to, but it doesn't have to be the 20 milliequivalents. Or you could still probably, for most kids, get away with using D5.45 normal saline, which, again, even in the last few years, has changed from our main one, probably now shifting up to D5.9 normal saline being our go-to. And got to add that KCl. And remember, LR is not such a bad guy either. Poor LR always gets forgotten on peds and internal medicine, but can be a good choice. Again, especially depending on the circumstance. And just remember that it's got a little bit different sodium concentration, 130 and 110 of your chloride. So a little bit different composition compared to, say, your normal saline, which again has your 154, or your 0.9, which is your 77. So a little bit different composition. So just be thoughtful. If you have a patient, for example, that's coming in with dehydration, is hypernatremic, then maybe in that particular case you might pick to use a different, you might pick to use a D5.45 versus if you have a patient who's hyponatremic and vomiting, you might pick D5.9 instead. So be thoughtful and just remember what's in each bag, and that'll help you get far.